Okay, so good morning, everybody. It's my pleasure to welcome you to the next session. First of all, I would like to cordially thank Yola for this wonderful meeting and for inviting us to come here, and it's been very impressive. Thank you so much. So together on the chair, or this session, I have the pleasure to chair together with Wolfram Nolte. Let me just say one or two words to this. I mean, I'm a colorectal surgeon or visceral surgeon. And Wolfram, as you know and have heard, is a survivor of colon cancer. But the special thing about the two of us is that I'm not a colorectal surgeon, I am his colorectal surgeon. And it really is a very special relationship in the setting of, well, in general, of course, but even more so in the setting of a genetic background. Now, we'll get back later to this during my talk. Because you're not just a surgeon who does a surgery and you never see the patient again. I mean, I don't know what your cultures are like in Germany. It would be like that. But you see these patients every year, and you don't only see a patient, you see the family. And the children grow up knowing you. And one of these days, if they happen to have a hereditary condition, they bump back into me. It's a very, very special type of relationship. And I think it's one of the things we need to build on, because we need to take care of our patients with emotion. And the genetic setting kind of like predisposes to that. But with having said that, I would like to pass on to Wolfram.
Just to describe my relationship to Gabriella, I would say if I ever would be in need for a colonoscopy, for a colectomy, I would refer to Gabriella again. So Gabriella, she put me into a favorable situation with time, so she sponsored me some time, but I don't want to stress your patience, although you are, as patients, trained in this discipline, actually. So I will speak to the patient's rights out of my perspective as a patient for colorectal cancer myself. So what do I have to do? Which one? The top one?
It's okay.
Yeah?
It's okay.
Yeah?
No, go ahead.
Yeah?
Go ahead.
Okay.
Go ahead.
Yeah. Okay. So I first
ahead,
want to introduce. So Gabriela has introduced herself already. So Guten Morgen. Then we have Sultan Kav from Turkey. Merhaba, hoş geldiniz.
Thank you. Teşekkürler.
And we have Antonio Gaudioso from Italy. And his surname is very promising. It means in English, joyful.
Oh.
So he is, I think he's justifying this name. So, on which one? Okay. No, that's not my. No.
Yep, it's there now.
Okay.
It's okay now.
Okay. Please help me. I'm not a technician. Okay. So, why I believe in patients' rights? I'm a survivor of a colon cancer and also hepatic metastasis. And I'm surviving since 4.5 years. My cancer was not impressed, or better to say, he gave a shit in my annual colonoscopies, because it simply grew in the time between two colonoscopies. That's called an interval tumor. So, but I was lucky that the reaction of my coloproctologist was immediate upon the first signs. The first signs that was shortly after Christmas and after New Year. So it is quite familiar that you have maybe some stomach problems. It was not really pain. I just was feeling uncomfortable. And when it lasted 2 weeks, my son said, "Why don't you ask for an earlier appointment? Why do you wait 3 months?" So I called her, and she said, bring your bag with you for 2 days and be here tomorrow. And 4 days later, I was on her table. So, simply said, I enjoyed one of the natural statutory rights of patients to receive the best available state-of-the-art treatment. After surgery, I was sent to one of the German avant-garde oncology clinics. My KRAS type of cancer was attacked with an individual therapy including Avastin. I was integrated into a study group. And this resulted in a full remission. And the therapy, chemotherapy, has now been ceased since 1.5 years, and I'm feeling very comfortable. Again, I enjoyed the best available state-of-the-art therapy. However, this is not the rule. I personally was just lucky to have met Gabriella before. I have seen other proficient professionals and other patients I know or I have heard of did not. To make it a rule is one of our jobs as patient advocates. We have to fight for patients' rights. We have to empower patients. Why I don't believe in patients' rights, on the other hand, is we have a new body of law in Germany since February this year. It defines patients' rights. But frankly said, the package says something different than the content. Still, the patient has the burden of proof of medical malpractice. How can a patient be cleverer than the doctor? Only in serious cases, the law says, the burden of proof will shift to the doctor. But then the question starts, what is a serious case? And there we come to experts, because the court, the judges, they are no experts. So they will ask an expert to tell them. And the patient stands there and he has no right of refusal, even though he has strong evidence that the expert is suspected to be biased. And this also applies when it comes to expertise about medical malpractice, even if it is known that the expert regularly is in charge of the liability insurances of the opposing party. I think that is something which is necessary to be changed, and we have to fight for it, and we all as patient advocates, we can do that. Thank you very much. Yeah. So I call Sultan. Sultan has unfortunately some health problem, and she has spent this night in hospital. So I think it is fantastic that you nevertheless are coming in order to deliver your presentation. Thank you. Thank you very much. Okay.
So, first of all, on behalf of European Oncology Nursing Society, I would like to, press my thanks to organizer Yola, Julia, and Katya, and for this wonderful meeting that I enjoyed yesterday as well. So my topic would be the adherence, the importance of the adherence to treatment. First I would like to ask if you have been on the oral medication for your cancer treatment. Did you have oral medication for your cancer treatment? Like capecitabine? Yes, you had. You had. So I would like to hear your experience also while I'm speaking. I have no conflict of interest except being a past president of European Oncology Nursing Society. So when you are on IV chemotherapy, you have been under supervision of healthcare professionals, especially nurses, to take care of you. And I mean, you have a well-educated, and you have the control over, and so you have also the number of the nurses or hospitals to call, when you have trouble at home. So, but we know that the new agents will be available only in oral formulations, especially for targeted agents. It used to be 95% of the chemotherapy drugs have been available as IV formulations, but this percentage has been decreased. Now about 80% of the drugs available in IV formulations, and more drugs will be available only in oral formulations. So, I mean, there is a good how I say that, there are advantages to having oral medication, because you don't need to go to the hospital, you don't need a needle, and you don't need, painful procedures, and but of course there are other aspects that we need to consider, because this puts you on, your control, under your control for taking the medications appropriately, and also about the safety issues that, haven't been well addressed, because the whole safety issues, like how to store, and what you do when you get vomit after the drugs, and how to handle if your caregiver, gives the drug to you. So there are many issues that we could list. So why important? Because you take the drug over the time as recommended, and the people may think that there is an assumption also that when they prescribe you a drug, and when they say that how to take and when to take, they assume that you are taking as recommended. But this is not enough, and we know from the studies that only the 50% of the chronically ill patients undergoing, or people, I don't want to say patients, people undergoing long-term treatment are adherent. Means that the half of the patients, they don't take the drug as recommended, and they don't take the, the recommendations has been, recommended by healthcare professionals. And of course, there is an assumption that adherence would not be a problem for cancer patients. And I would like to ask if you did have any, problems, because the people think that because of the seriousness of the disease, people will careful about that, and maybe there would be adherence would be a problem. But from the studies also we know that there is never 100% adherence to the therapies, and these are the large studies. For example, this one for the CML patients. And the other studies also from the breast cancer patients, that we know that there is no. And why important? Because drugs don't work if the people don't take them. So that's could be as simple, but of course there are many reasons behind. So why we are using the adherence? Because it's because it in the past also it has been used as compliance, but the compliance means just the receiver responsibility, and the adherence is like more agreement between the healthcare provider and the receiver. So and in cancer care there has been an increased attention into adherence recent years, but it hasn't been addressed well in the past years and can be a greatest barrier. And there is two definitions. One by the WHO. It's similar to each other, but WHO defines the adherence as a person's behavior, like taking medication, following a diet, lifestyle changes, and corresponding with agreed recommendation from healthcare provider. And another definition from the International Society for Pharmacoeconomics and Outcome Research They used adherence as synonymous with the compliance, and they stated as the degree or extent of conformity to the recommendation about day-to-day treatment by provider with respect to the timing, dosage, and frequency. And also it includes the management of the side effects and what to do if you face the problems at home. And also the compliance and or adherence and persistence issues has been appeared, because the compliance would state the percentage of doses taken as prescribed from the beginning till the end. For example, if you are taking capecitabine about 6 months, you have the cycles. You take the drug on certain days, certain times. You have the breaks, and you know it's continuous. But this is a number of doses taken as prescribed, and this is also you know without having the not exceeding the permissible gap in the taking the drugs. For example, if you are taking on 2 times per day, if you are taking on certain days, so you need to be on the recommended period. So there are some, the methods to evaluating or measuring the adherence. The subjective measurement by asking to people, family members, caregivers, and physicians about the use of medication. This is also the one of the highly used methods in clinical practice. And another one, objective measurements. But there is also, we cannot say that this is objective because, for example, with this electronic medication monitoring system doesn't tell us about patients or people really take the drug, because it counts when you open the box. Other methods would be the biochemical measurements by looking at the blood level or serum level of the drugs. But this is not practical. It has been only used for the trials. So nowadays, the combination of the methods has been used, mostly the subjective measurement. And there are dimensions of the adherence that many factors would be associated for or could be a barrier for the adherence. Such as health system factors, social economic factors, therapy-related, patient-related, and condition-related factors. And non-adherence needs to be also addressed and defined. And it can be influenced by many factors. And it could be, the hesitance to initiate the therapy, skipping the dose, medication discontinuation, self-adjustment, could be the over-adherence, and inappropriate drug administration. Because when we say the oral medication, the patient may think or may, perceive as differently, or people may, So we need to clearly define how they perceived or how they understood the medication administration. This is the findings, from one of the recent systematic review about what would be the determinants for the medication non-adherence and non-persistence. And this has been listed as the factors from the 25 studies that they have reviewed. And disease-related, the comorbidities, we all know that with the increased age, we have more chronic disease, and when we may have the hypertension, also the diabetes, so we may have other drugs in parallel with the oral cancer agents. And history of antidepressant use has been found also the factors may be related to non-adherence. And also the side effects, if we have the longer duration of the therapy, we may see more And difficulties to swallowing tablets and inconvenience might be another factor, and timing and type of the drug. And so when we say the non-adherence, we need to look at if it's unintentional or intentional. So if for intentional, such as the concerns about symptoms, lower perceived necessity by the patients, it's really important that, you know, we need to explain what would be the treatment outcomes or expectation from the treatment. And the opinion that missing dose makes no difference or lower perceived quality of life. And for unintentional forgetting or accidentally taking too much of prescribed drugs. So, and from that studies also self-efficacy and the belief that medication intake as being prescribed would help to cure from cancer would have the positive impact, and negative beliefs about the, you know, the effect of the drugs would have the negative effect. And the higher educational level and merit status has been found as the positively, you know, impacting factors, although the younger age, older age has been found as, and female gender, and higher cost. And also the enhanced knowledge of the disease and treatment, and longer duration of the first visit, and the nurses and phone follow-ups has been addressed or noted, reported as the positively influenced factors. So these are really important, that, but although we don't know that the education would ensure the 100% adherence, because there are other factors. But we need to look at as whole, and we need to focus on different strategies. And shorter duration, I mean, as opposite, as you see the other factors, for example, different doctors responsible for follow-up, and it brings that lack of the coordination of care aspects also, and less or too much support than needed. And these are evidence-based strategies, has been indicated as effective for the medication adherence, like counseling, written information, phone control or phone follow-up, and combination of care, reminding, sending a reminder. And they are also working on, like iPhone. You had the automatic reminder about your the drug, and nurse and phone follow-up. And there is also a tool that has been developed by Multinational Association of Supportive Care in Cancer, and this includes the different section for patient education, evaluation, and assessment questionnaire that has been available in different languages that can be used by the healthcare professionals. And this is also another strategy that we need to respond all these questions when we are educating. So, as summary, medication adherence is not only the responsibility of the patients, and its medication taking behavior is complex and involves the other healthcare professions, especially nurses. And some solution would include encouraging the blame-free environment, less frequent dosing if possible, and improving the patient education, assessing the health literacy, paying attention to non-adherence, and also the follow-up. So, I think my slide is here, so can we go to questions?
We will have to rev up a little bit because we are behind time. And so, yeah.
Okay. Okay, the first question, who provides for patient and family caregiver education in oncology? Yes. Is it green watering? Yeah. Okay. So, good. The reason that I put this question, because when we had the study from 15, looking at the countries around the world, if the nurses involved in patient education and follow-up, we have seen that it's, almost half of the, we looked at the 1,000 and almost 200 nurses in 15 countries, and they have not been involved in patient education, and they see that it's not their role. They give the IV chemotherapy only. So it's important, and it's getting more and more nurse involvement, and it's, the patient receiving oral agents, they deserve also the education by nurses and follow-up from nurses. And the second question, do people beginning oral therapies need special education? Okay, of course. I wonder the 11%. I mean, giving the prescription would not means that you have all information. That's really important. So the third question. So what are the challenges around adherence to treatment? I mean, it could include your experience. Side effects. And okay, so we have been reviewed the factors influencing. So you have these answers. And final questions. Sorry. So what strategies would be effective to improve adherence and the patient outcomes? So, thank you. Thank you. This was my last question. So, thank you. I think I'm
Thank you again.
over the time. Sorry.
Teşekkür. Thank you.
If you have any questions.
I'm now pleased to hand over the word to Antonio Gaudioso of an organization called Città Danzativa, and he will explain what that means. I'm sure about that.
Good morning to all of you, and it's a great pleasure to be here with you today, and I have to thank my friend Yola for this opportunity, because it's not only a great opportunity to share experiences, but also to learn a lot. I was putting on my agenda all the things that I learned yesterday and today, and I have to say that it was full. And the second thing is that you know that it's very challenging to ask to an Italian guy to be brief. So this is the first and most important point for me, to try to put everything together. And I will promise that I will do my best. And I hope that will be enough. And Città Danzativa, in English it means active citizenship, is an organization that in Italy started 35 years ago to promote the civil participation and the protection of citizens' rights. At the beginning of 2000 and 2001, started our European network, Active Citizenship Network. The idea of the network is to give the voice at the European level to the organizations that are not so big at national level, to have an European voice, and working together to give a stronger possibility to the European citizens to influence the change. And we are working in some areas, but mainly in health. Is a network of the European network is a network that is in 30 European countries. We have no formal membership, but we're working together on several projects, and more than 60 organizations are participating in our activities, and more than 85 are regular members. At the beginning of 2000, in particular in 2002, we promoted the European Charter of Patients' Rights. Started with a group of 12 organizations, patients groups, consumer organizations, several organizations that were coming from different countries with common aim to take care about the rights of citizens in health. And so, in fact, are included several kinds of organizations, grassroots organizations, family members, organizations, and so on and so forth. And I have to remember that one of the first organizations that has participated in this work was coming from Spain, in particular from Barcelona. Dr. Alberto Jovel was one of the members of the first team that has drafted this charter. The aims of the charter is to create an European public opinion on patients' rights, to promote a higher degree on protection of rights, and in particular to promote the participation of citizens' organizations in healthcare policies. And about the contents, we have several rights, in particular 14 patients' rights, also to link it to the legal framework. So not only rights, but also linked with a concrete possibility to get that these rights are completely respected. In 2007, two resolutions of the European Parliament called about an adoption of the European Charter of Patients' Rights. And at the beginning, in 2007, the European Economic and Social Committee has approved an opinion on patients' rights that has adopted the charter that was promoted by this first group organization and then enlarged all over the Europe with several organizations that have decided to be part of. This is the charter. It's important for us to underline, as I was mentioning, that the charter is also linked to concrete rights that both at national and European level can be pushed to be respected. In particular, the 11th right is the right to avoid suffering and unnecessary pain. So you see there are several that are linked with the things that we are discussing about. So, for example, the right to the consent, the respect of patients' time, the right to innovation, and so on. After the draft of the charter, 2 years ago, we have promoted something that we have named civic audit, involving the organization of different countries to verify the respect of the rights daily, concretely in each country. And as you can say, the right to avoid unnecessary suffering and avoiding pain is one that is less respected at national and European level. So we have a lot of things to work on. And we have used all the information that we're coming from some interviews and actions of the organization in each country to have a rating, to give a rating for each right, and as you see, we have a lot of things to do. So we have two different levels, and I would like to mention about what is the difference between what you say in general and what's happened in reality. At the European level, is as you see, that it's hardly expected. So there are a lot of things that each country must be done in each country to guarantee that concretely is respected. But as, for example, happened in Italy, we are promoted 15 years ago, started with several other organizations, economic organizations and so on, a campaign to promote a new law that giving you the possibility to take care the best about pain. And now we are, maybe the law that was approved 33 years ago is the benchmark at the European level. But There are two different things. The law is perfect. The reality to get this law concretely implemented is very complicated because it's not only happens in Italy, but in several countries, each region also to guarantee, to save money, trying to delay the concrete application of the law, in particular about the empowerment of citizens, about the possibility to give more treatments to reduce the pain. This is our commitment on unnecessary pain, protected the right of violation reported by individual citizens, collection and dissemination of good practices, producing civic information that coming from the concrete experiences of the citizens, and then promote actions to guarantee the implementation in each country of this campaign. We have promoted the civic survey on the respect of unnecessary pain, patients' rights in Europe, and we have done. We are differentiating the work campaign for for cancer and the work campaign for non-cancer illness. So we have promoted work to develop EU pain patient pathways recommendations using the information that we have collected from the single countries, and we are working right now to submit these civic recommendations to vote to the European institutions during the Italian EU presidency on the second half of 2014. This is finally things that it happens in Italy. You know that Italy, apart spaghetti and pizza and so on, is famous for the number of governments that we change every year, 2 years, and so on. You know that now we have new prime minister that is not bad guy, in particular comparing to the previous ones, but he's a good guy, quite young. We have a good relation with him. And when he started 3 months ago, all the columnists was thinking that he has to survive for no more than 6 months. Maybe someone is saying that now can go beyond in a couple of years. We told them, if you like to survive, maybe the best thing is to use the campaign against the pain as one of the key points of the Italian presidency of the European Union that will take place the next year. And you are working with this to use about health. This is one of the pillars of the work of the Italian presidency for the 2014. So, the survey that we've done is working on 2 areas. Non-cancer pain as a recognized right across Europe, and to make the right to avoid unnecessary pain and suffering a priority in Europe. We are promoting right now, we are working in this period with a campaign on oncology, citizens, information and empowerment. So the idea is to have a wider number of citizens involved in this campaign, because the idea is to give not only information, but in particular to empower the people, because each person that is empowered could be a good testimonial to work on this, and using also friendly and understandable language, and to contribute to orient the people, and to promote the awareness of the rights, because if the people are aware and empowered, can contribute concretely to change. So because in our opinion we have to go beyond something like a paternalistic approach. So we are asking that someone has to take care about ourselves. We can work this directly, facing the problems and contribute to find the solutions. So some examples of contents about the campaign. Prevention, progressive screenings, to pay attention to the pain in the hospital, on the territory, in integrated home care, in the hospice, to work about the access to the health records, to access to care in disparities, and choice of places of care and therapeutic alternatives, and about also in particular about services and useful references for the citizens. Also because you know that, as I was mentioning before, the problem is that we are not speaking about the differences about country by country, but inside the same country by cities, cities to cities. In 2012, we had promoted a civic survey on oncology about the personalization of care, respect of time, and informed consent. And the idea is every time is collecting information, working to empower, give the possibility to use these civic data to try to change the things. But, for example, in our experiences that, and about the data too, what's happening that too many cases there is a problem about respect of the time and informed consent. Speaking about respect of the time and speaking about the waiting list that are too long for the number of people that are looking for the access to the treatment. Okay. Something about the issues reported by patients. The pain level is not recorded in the sheet case. The citizens are not actively aware about the contents of diagnostic and therapeutic care pathways. There are problems about informed consent. So many times, in particular when we are treated, the information that coming that someone saying you, okay, there is a sheet to sign. If you don't sign, I can not take care of you. That is completely different approach about what we are speaking about. The possibility to create a link stronger between the institutions, between the hospital and the citizens that are asking to be treated. Some proposals. The idea to promote the PDTA, the diagnostics and therapeutic care pathways, and recording the pain level on the case sheet, psychological support for patients and their families, innovation technology as a tool for healthcare system sustainability, and active role of individual citizens and public organizations and patients. Because the involvement, the participation and so on is a way to manage the best the system. One thing that I would like to underline, that you have two ways to take a look about the citizens. Could be a problem or an opportunity. You usually take a look as the citizens, often the public bodies, like the point of view of the risk manager. So if I manage the citizens, I can prevent problems. So you are the citizens, do your business, I do mine. I can take care of you. But in other way, as we are speaking about the empowerment, if you empower the people, you can involve them and manage the best problems before you have. And in particular, the right lifestyles and what else, as we were speaking this morning. Oh, wow. I finished. Just 56 seconds later. So I think that you can appreciate it.
Great.
And so, about the questions. I can use this? It's the same?
It should be the same.
Okay.
Yeah.
Should, in your opinion, the fight against unnecessary pain be a priority for healthcare systems? Yes, no, or yes, but there is lack of public funding to cover this need. good. But I see that there are a number of people that taking care about the money points, and I can understand that there is a point, but we have to find a way to go beyond. Second question: how is the level of access to the treatments for pain in your country? Good, acceptable, but should be better, insufficient, or very poor? Yeah, I have to say that it's very interesting, and in particular about more than one third of the people thinking that there is a lot of things to do, and for this also should be a priority to work on for an alliance of organizations. Question 3, please. How can you assess the patient organization involvement in development of public policies on pain in your country? First, good, work in progress, insufficient, or no public policies active? Okay. Now, good, I think that is disappeared. And one thing I would like to say, just to close with a comment, that is, this is precisely the point. So, if you say that there is 50 that is speaking that there is a work in progress, sorry, working, another more than 50 people, that 50% is saying that there is insufficient or nothing. The problem is what I was mentioning before. The self-referential approach doesn't work by the institutions. Or you have a way to create an alliance between the different stakeholders, or there is no chance to have the possibility to change with a long-term sustainable approach, not only for the health, but also for economic sustainability. We were speaking about the adherence before. We were speaking about several things. If there is no trust between citizens and institutions, there is no way to change it to have a bad system. So also for this reason, it's so important to work together. And for this, I would like to say again thank you to Yola and Europa Holland for this kind of invitation. Thank you again for your patience.
I must say, Antonio, your timing is excellent, and that's the best combination: German charm and Italian precision. Now I can hand over to Gabriella.
Thanks, Wolfgang. So thanks again, Yola, for putting this topic this very neglected topic onto today's agenda. So what is the impact of genetic history? Is it important? It should be, but it actually is not. Which one do I have to press? Yeah, it's not working.
Pfeil rechts.
Okay, thank you. Okay, well, the impact should be enormous, but it is not, because we're just not looking for what is right under our nose. So what are we talking about? We are talking about 5% of colorectal cancer patients who have a hereditary condition. This is not familial. There is a clear difference between hereditary and familial, because hereditary is passed on from generation to generation. What are the characteristics? Patients are younger. Usually in these syndromes we will have an autosomal dominant pattern of inheritance, which means that it does not depend on gender, and it will, if you have one allele, only one gene from one of your parents, you will develop this condition. If you had a cancer, unfortunately, you've not necessarily done your job, you might get another one. And that's quite frequent in this setting of hereditary predisposition. Now we have the chance, we should have the chance of identifying at least the people who get their first cancer if we look for them, if we do not know the families yet. And if we do find the index person with a cancer, we have to think about what type of surgery are we going to do. Do we have to talk to this patient before his surgery about possible things that would improve quality of life or cancer occurrence? And I'm thankful for Luc, who mentioned breast before, and Angelina Jolie, who I agree did a wonderful job in the way she brought to attention what is happening in hereditary syndromes. However, she gets a wonderful amount of awareness. I'm not jealous, but I'm just think we should, for colorectal, deserve the same amount of awareness. But anyway, do you really think people would be attracted by Angelina Jolie saying, or telling people, okay, I had prophylactic surgery of my colon, and I do have to go to the toilet now 3 or 4 times a day? It wouldn't come over the same way as I had to have my breast removed because of a tremendously high risk of breast cancer. So we're dealing with the same thing, but we have a very inferior communication and lobby. So actually, every organ that we have has a 5% risk of developing a cancer, a hereditary cancer. So everywhere we look, we should look for it. Breast cancer, gastric cancer, all of the cancers that you see. And I would like to now, because of our topic, focus on the colorectal ones, which are the ones that you see circled, not without first telling you what is happening in other organs. For example, in hereditary thyroid cancer. How do we deal with hereditary thyroid cancer? You know how we deal with hereditary breast cancer. We can either screen with bad screening or do a prophylactic surgery. Now, this is paradigmatic for prophylactic surgery. If there's a hereditary thyroid cancer, we call this MEN2 syndrome. Don't worry about it. One of the parents gets a medullary thyroid cancer and might be young and might have a physician who's aware of the condition and who might do molecular testing. If a mutation in the corresponding gene is found in the parent, then we have to offer predictive testing for the kids, and we do this at a very, very young age. Now, the predictive testing means we take a blood sample and look if the child has the same gene the affected parent has. And if it does, we remove an entirely healthy-looking organ from a child before it starts to go to school, age 4 to 5. That's what we are talking about in what we can do in these syndromes, and we have to, because otherwise this child will probably have a metastatic thyroid cancer at the age of 8 or 9. So that's the most, I would say, most severe type of prophylactic surgery that we have to do in these syndromes. And let me tell you that, or just quickly show you some syndromes, because we say syndrome because in all of these diseases, it's not the colon that is affected or the rectum, it's usually the colorectum and other organs. And just to give you an idea of what syndrome means, for example, this is Lara. Lara holds, at this age, held a black belt in judo. And she has something strange on her lips, which are black dots. Now, you will not, we call it lentiginosis. You will not find that with anything other than with the Peutz-Jeghers syndrome. It's very classical, and you should, as a physician, recognize this. And I'm not going to start telling you stories about the kids that come to our department and have not been recognized, although they clearly have those marks. What happens? These children tend to get polyps in the small intestine, not in the large intestine, and they kind of like move the small bowel into each other, and they get an obstruction and a lot of pain. So it leads to the fact, if they're not recognized early, that small bowel has to be removed. And as you know, we cannot live without small bowel if we don't have enough of it, or it gets very difficult. In contrast to the colon, we need our small bowel. And in later age, these patients get a fairly high rate of colon cancers, gastric cancers, small bowel cancers, females, breast cancers, and other cancers. But the first sign would be in childhood. That's where we should recognize it. Familial adenomatous polyposis, FAP, has epidermoid cysts, as you see in the upper picture, osteomas, and those are entirely, they don't have any real meaning. They don't turn malignant or anything. And then we have the polyps in the colon, which in this case are adenomatous polyps or adenomas. You can see these signs at early age. Children that have these signs should be screened for polyposis. Now, they also have, in the lower picture you see, also you might see black dots. These are just pigment cells. They have no importance, but they could be relevant for an eye doctor who looks at a patient and sees them and says, hey, what's that? I know that corresponds to polyposis. Let's have a look at your colon. And the other thing these patients sometimes develop are so-called desmoids. I'll not get into that, but just trying to show you they have a variety of things, and the physicians dealing with this disease have to know how to cope with them. We do prophylactic surgery, essentially a removal of the entire colon and rectum with an ileoanal pouch, which means you take small bowel and you make a reservoir. Patients have a quite good quality of life in this condition. We tend to have to do surgery at the age between about 18 and 22. The youngest patients that needed the surgery were 8 years old that I had to do surgery on. And nowadays, quality of life is really an important asset. We do the operation laparoscopically. On the left side, you see the daughter, on the right side, the mother, and you might see the difference in the surgical scars that they have. And it's not only the surgical scars, it's also the quality of life, because they really do better if we do it laparoscopically. Now, the next setting is Lynch syndrome, or so-called HMPCC, hereditary non-polyposis colorectal cancer. Now, patients might be young. They don't have to be young. In this case, a 45-year-old female who had a colon cancer. And you might be aware to say, well, 45 is not the average age for colon cancer. The average age is about 65. So what's wrong with her? Does she have polyposis? You can easily look at her colon. If she doesn't have hundreds or thousands of polyps, she does not have a polyposis. So you have to ask yourself, is this just chance, bad luck, Milan, or is it something else? Is it something hereditary? So we have to look at the family history. It's the first thing, and sometimes you will be amazed at the substantial family history that you will find. In this case, the patient's mother had ovarian cancer and endometrial cancer at a fairly young age. The grandmother, endometrial cancer. On the father's side, malignant melanoma, prostate, ureteral, and the grandmother, cecal cancer. Now, usually in European countries, father and mother are not related to each other. So when you look at a pedigree, you draw a sharp line between the mother and the father, and you look at each side in order to evaluate the pedigree. We have a very, very easy and very, very cheap method to detect these families if nobody looked at family history. If we tell our pathologist, and we're trying to do this systematically by saying we need this for all patients with colon or rectal cancer, and if we would do this, we would identify a very large amount of people with this condition. It's very easy to do immunohistochemistry. It's just a staining for the pathologist, and he looks at 4 genes, and it is a little bit more complicated than just immunohistochemistry. In one of the genes, in the other 3, it means that you have Lynch syndrome. And then what you have to do is go to genetic counseling, get everything explained, and you have the option, the recommendable option of looking for the actual mutation in your blood. And if you find the mutation, or if the mutation is found in blood, then you can offer predictive testing for everyone in your family, right? So it means a blood test for the family. And this is 100% sure that you can find out if your loved ones have this predisposition or not. And if they do, you can help them. We can offer surveillance. You all know that colorectal surveillance is quite good. It's not as good in this condition, but it is good. And those of you who were here yesterday might recall the title, Detection of MMR Deficiency. We heard about MMR deficiency yesterday as a molecular marker in the context of altering the chemotherapy that you might require for a stage 2 cancer. Now, that's really important, but I'm sorry, this is much more important. This is much more important because it affects so many people that could easily be recognized. We need to do this test in the biopsy prior to surgery for every, again, I know it's a political issue, for every colorectal cancer. We should do that. And if we do, we will be able to discuss with this patient if the patient would like to have the normal surgery, which, as you may know, we have standards in surgery. If the tumor is on the right side, we do a right half hemicolectomy, or on the left side, the left one. So we have certain segments that we need to take out if the cancer is at a certain place because of the blood and lymphatic supply. So in this condition, we should talk to the patient if the patient might like to have an extended resection, because that would mean No more colonoscopies, once a year, recommended once a year, and a dramatic reduction of the colorectal cancer risk. We did a large study of quality of life in these patients, a large international one. I don't have time to get into it. The quality of life for these patients is identical. They have a little bit more frequent bowel movements, no question about it, but the measured quality of life is equal. The surgical risk, as you see here, is also equal because you have one suture, which is what makes the risk. Now, our patient should never, ever have gotten a colorectal cancer because she has 3 sisters and 2 of them already had an endometrial cancer or an endometrial and ovarian cancer, were younger than her, and nobody ever told this family that they have Lynch syndrome. Now at that time, just one clarification, Lynch syndrome is hereditary non-polyposis colorectal cancer with an identified mutation. Essentially it's the same. The difference is the mutation finding. Clinically, they're very similar. So actually, we changed the name, or the name hereditary non-polyposis colorectal cancer for this syndrome was changed because it doesn't only affect the colon and the rectum, which makes it even more difficult. It should be called endometrial colorectal cancer syndrome plus other cancers, because endometrial cancer is just as frequent, if not more frequent, than colon and rectal cancer. So we're trying to do the same thing for endometrial cancers. We're trying to get immunohistochemistry into a standard for everybody who has the cancer. Now, why would we even discuss extended surgery if we can look for polyps, remove them, and these patients wouldn't get a cancer even if we don't do extended surgery? Well, the problem in this setting, again, we're talking about hereditary cancer. We do colonoscopies once a year in these patients, is that we do not really detect all of the cancers. And here you see the metachronous cancer rate, which means despite surveillance and having had a cancer once, how high is the rate of getting another cancer? It's 18% after 12 years, 36% after 23 years, and more than 50% after 26 years, despite yearly colonoscopies. So something here is not working the way it should. Henry Lynch, 1977, said, you should recommend extended colectomy in these patients. 1977. At that time, it was gut feeling. And my, did he have a good gut feeling. So, to sum it up, we are talking here about personalized medicine, which should be clinical practice today. We're not talking about cost. This is cheap. It is cost effective. But much more than that. It's easy. It's family history. It's doing the immunohistochemistry in these tumors. It's the option. If you know you have an increased risk, you have the option of changing your lifestyle habits. We know very well that smoking increases the cancer risk in these families. You have the option of intensified surveillance. You have the option of prophylactic surgery. You have the option of optimized chemotherapy, as we heard yesterday, and you have the option of chemoprevention. Luke mentioned that for these patients, we really recommend low-dose aspirin. So these are your patient rights, coming back to that topic. You have a right to know your own risk, especially if it can be identified with such ease as it can today. And last but not least, you have the option of cancer prevention in your own family. Thank you for your attention. Time to vote. So, I have a couple of questions for you. Oh. Okay. Did you ever think about or try to discover your own family medical history? Okay, well, I'd like to take that number home. I mean, this is such an evidence that we need to do so much more in this field. I mean, I think there are a lot of patients in this room, so this is a disaster. It's just a disaster, right? So the next question, if you feel that physicians do not appreciate the significance of family history, do you believe patient organizations should be able to help? Actually, the background, before we put the timer on, if it's still possible, the background is there are, I know a few patients in this room, they go to their physicians knowing that they have Lynch syndrome, and they go to screening, and the physician says, yeah, that's fine, your colon was clean, come back in 3 to 5 years. What do you do as a patient if you're told that? Well, one thing is you're going to think, oh God, the other doctor, well, who's right? I mean, she's telling me that, he's telling me, who do I believe is one thing. Well, that's your obligation to get your own information, right? It's very important. You all, with this syndrome, everybody has to know more than his physician. But what do you do in that situation? You are very insecure about who's right. And the other thing is, I mean, health systems are different, but you need that GP to get your next colonoscopy. And you also need to get an endometrial biopsy once a year. Tell that to your GP, he's going to see this lady's mad. So, you know, we really have a problem there. But having said that, what would you do if you are in that situation? Do you think that patient organizations should be able to help? Good. I think that's something that we should also take home. We have in Germany, as you may know, and I'm very happy and excited that from Germany there are so many representatives from our new patient support group that are here. So we know what we have to do in Germany, and we know what we have to do in Europe. So, and what can we do to improve the situation? How can we reduce the impact of family history on health? Another take-home message. Okay, so I would like to, I think those were all questions. I had 3. I would like to conclude with one short report. We made, because we are aware of the unawareness, we made a monkey survey simulating that not for patients in that case, but for experts in the field, and we distributed via the societies that have a lot of experts, and we got, to my disappointment, 150 answers. I thought it was disappointing, but actually it's pretty good. Asking if you were known to have a mutation of a Lynch syndrome, of a mismatch repair gene, so you know you have a 80% risk of getting a cancer, probably a colon cancer, etc. So if you had that risk, if you know you have that, what would you do? And for all of the settings, it was an amazingly high amount of the experts who opted for purely prophylactic surgery, which we are not necessarily recommending in this setting. We wait for cancer. For purely prophylactic removal of the endometrium, which we do recommend after family planning is completed. And almost all of them wanted to take 600 milligrams of aspirin. So with that, I would like to conclude. Thank you all.
Thank you, Gabriela. Thank you, all contributors to this section. Thank you very much. Let me conclude with some impulses. I think you all know that the word patient is coming from Latin. And in Latin, it means a person who is suffering. So it is enough that patients are suffering from their disease. They must not suffer from other circumstances, as imperatives in law and so on, or neglectance by healthcare stakeholders. I would recommend to doctors, and that is something which I really can say as an appraisal of my personal doctor here. It is not about healing or curing a disease. It is about healing, curing a patient, a person. So we have to look in the total. And just let me conclude, I hope this much time is left, with a little story from my little village where I live. I have a neighbor, he is a plumber. You all know what a plumber is? That's a guy who is a pipe fitter, who is installing the pipe work in the house. So Saturday afternoon, after a busy week, he's sitting at the table, just lifting his teacup. At that moment, the telephone starts ringing. He's sighing and putting down the cup, picks up the receiver and answers. And the doctor, he knows him, is on the phone, and the doctor is really panicking. He says, "Hey, Andy, you have to come quickly. My cellar is flooded with water." So it is not far. Andy takes 10 minutes for Andy to ring with the doctor, put down his toolbox, says, "Okay, where is the problem?" The doctor opens the door to the cellar, and indeed, the water is standing half the stairs up. So, says, calm down. The doctor is leaping up and down. Calm down. And I'm a specialist for that. So he goes to his toolbox, opens it, and takes out 3 rubber sealing rings, and he throws them down the stairs into the water. Then he pats the doctor on the back and says, "Okay, now you have to be patient. If it is not better on Monday, give me a call."